And I have a riddle for everybody. This is a delightful fruit. Now, two questions for you. What makes a fruit a fruit? Which actually is much harder than you think. So one, what makes a fruit a fruit? And two, um, what is this fruit? Is it an orange or is it a tangerine, and why? Good luck. More importantly, we already have a case presenter by the name of James Plum, who emailed us saying that they have a wonderful case, very exciting from their IM rotation. So, since instead of a reflection, I have left you with a riddle. What is a fruit? And what is this fruit? If it is a fruit, it may not be a fruit. This fruit is. Um, I feel like
If a tree falls down and no one is there to hear it, does it make a sound?
Ah! All right, meeting over. James, please unmute yourself, introduce yourself, and end this utter chaos.
So my name is James Plum. I'm a third-year medical student at Midwestern University. So I was on a in-service inpatient IM rotation when we had this case. I was with a team of residents from the University of Arizona. And we all thought it was a pretty cool case. Actually, we presented it at one of our morning reports. And so it's a really good learning experience for all of us. So hopefully, it's the same here. And so I got separated into 5 aliquots for you guys. And so I'm just going to start off with a one-liner. So we have a 31-year-old male that's presenting with a 2-day history of intractable nausea and vomiting, diffuse abdominal pain, and shortness of breath.
Great. I'm not sure who's scribing, but I'll give them a moment to catch up. But what I really, really want to know is the medicine is going to be fascinating. I'm curious to get to know you a little bit better, James. Tell us a little bit about your life outside the bubble of medicine before we jump in and reflect on the doozy of the case you're bringing here today.
Well, I listen to a lot of podcasts.
Yeah.
Definitely Clinical Problem Solvers being one of them. Actually, I think I heard you guys from Cardio Nerds.
Yeah.
Are one of the ones I listened to. They mentioned the MIST mnemonic for altered mental status, and so that's how I'm finding out about you guys. But
James, they just basically copy everything we do,
and
put it on their podcast.
It's been a while since I've listened to them. It's mostly you guys and Curbsiders. So I listened to both. I drove in Yuma, Arizona currently. I drove to from Tucson just yesterday. So got a lot listening in. Learned about what was it? Obesity hypoventilation syndrome and some instrument called for some reason. So
man, you knowledge. Look at you.
But wait, what was it?
Oh, I was just reflecting on the fact that you are medicine through and through, because I asked you an open-ended question about your life and you're like right back into medicine, which I think is
I feel like before medicine. So I was prior military, actually high school dropout. Never liked school. Thought it was boring. Thought school was for suckers, and then here I am in my 7th year now.
Incredible. What's quite a story. Well, I can't wait to get to know more about that very intriguing thread that you threw in the end. We'll definitely explore it going forward. I'll go back to the case and maybe I can talk about nausea and vomiting and leave the accompanying symptoms for Reza to talk about. And there's 2 reasons I'm doing that. One is because I'm going to tell you that the nausea and vomiting don't matter as much as the accompanying symptoms. And 2, I think the way Reza describes the shortness of breath pyramid is just beautiful. So when somebody has nausea and vomiting, in most cases, nausea and vomiting do not serve any diagnostic utility, but they are very helpful in serving as a barometer for the severity of the syndrome before you. It's no different than sinus tachycardia. If you walk in and you hear that a patient has sinus tachycardia, anything from their head to their toe could be going on. Anything from meningoencephalitis to a toe fracture can cause sinus tachycardia, and the same is true for nausea and vomiting. Now, the worse the nausea and vomiting are, the worse the syndrome is, and the more thoughtful you have to be about what's going on. And so the journey of nausea and vomiting is, do you find anything else to pair it up with? And if you don't, then there's an approach for nausea and vomiting that's isolated, which is not the case here. So if you do arrive at that, I'll tell you that it's a very different world where you meet many, many, many other friends. But those friends are probably not at play here because we do have some company. In fact, a lot of company, both abdominal pain and shortness of breath. So I'll pass the mic to Reza to reflect on.
Thank you, Ravijan. James, thank you so much for being proactive and volunteering a case. For anyone else who's in the audience, please do this. Like if you have a case to present on Friday, send us an email. James, I'm going to ask you one question and then I'll share my thoughts. Which of these symptoms, the abdominal pain or the dyspnea, was more concerning to the patient?
So it was the dyspnea, and that's actually what ended up bringing him in.
Thank you so much, James. That really helps. And I'll tell you, even if James had not informed me that the dyspnea was the patient's chief concern, I would still prioritize it over the abdominal pain unless the patient had findings to suggest an acute abdomen, meaning coming in like in just so much pain. So what is the center of gravity of this case? It's the shortness of breath. Whatever is driving the shortness of breath is causing the abdominal pain and is causing the nausea and vomiting. So Robbie, rather than me just tackle this alone, maybe what I can do is talk about cardiopulmonary disease that leads to shortness of breath and how that might relate to abdominal pain, nausea, and vomiting. And then maybe you can layer in the other category that leads to shortness of breath, which may also cause nausea, vomiting, and abdominal pain. 95% of causes of dyspnea, which is subjective, unlike hypoxemia, dyspnea is subjective. You can't tell someone they're not dyspneic, is due to a cardiopulmonary disorder. And when you approach the cardiopulmonary disorders, you can take an anatomical approach with each bucket. So think about the heart. You have the myocardium, the endocardium, the pericardium, and the rhythm. Any problem with the heart that results in heart failure can cause abdominal pain and can cause nausea and vomiting. Any problem, whether it's a valvulopathy, whether it's coronary artery disease, whether it's pericardial pathology, whether it's arrhythmia. So now let's shift our focus to the lungs. And again, here, I want you to picture the lungs. You have the airway, the parenchyma, alveoli, pleural space, and the pulmonary vasculature. And the truth is, if you have a process in the pleural space causing inflammation, this can irritate the diaphragm and cause abdominal pain. And abdominal pain can lead to nausea and vomiting. What if you had something in the alveoli? Well, if you have an infection or some kind of serious pathology in the alveoli that results in maybe stress-induced cardiomyopathy, that can too lead to abdominal pain. I'm going to leave it there, but you can easily see how we can play this game, like a pulmonary embolism, right? Heart failure, congestion, abdominal pain, nausea, and vomiting. But that's sort of, I think, the best way to approach shortness of breath is to use the center of gravity of heart, lung, take an anatomical approach, and then cross-check which one of those pathologies can lead to the abdominal pain. I think the other category might be exciting to discuss as well.
Ooh, what a setup. The other category is one that you should be very tired if you're reaching it. Because if you are here in this world of the other category, that means you've climbed a pyramid that is so big that you've bypassed the lungs and the heart. But if you've arrived in this magical land, the probability is that you find anemia, acidosis, the two A's. The third A is less important, it's anxiety. So anemia, acidosis, and anxiety. A couple other things to keep in mind in the land of rarity is hyperthyroidism and neuromuscular weakness. Which one of these can also cause abdominal pain? I'd say the most important one is to worry about an abdominal catastrophe causing metabolic acidosis, like a lactic acidosis or DKA. But all those are at play. You could have a retroperitoneal hemorrhage causing anemia, and you can play table rounds with these connections all day you want, but the most morbid one, I would say, is abdominal pain causing an acidosis. But I'm sure we need a little bit more information, so I'll pass the mic back to James.
All right, so on review systems, he obviously endorsed the abdominal pain. He said it was pretty diffuse, but probably worse in the lower abdomen in a belt-like pattern. And he also did endorse some flank pain as well on both sides. He endorsed obviously the shortness of breath. He did endorse fatigue and weakness along with the nausea and vomiting, and also said that he has been constipated as well. And I can also now, didn't really have much of a past medical history, but he did have a past medical history of asthma, but not currently on inhaler and hasn't had to use one since childhood. No surgical history. Medications, he takes ibuprofen, and he says he usually only has to use it about once a week. For social history, no tobacco use. Habitual marijuana smoker, says he smokes at least every day. And then for alcohol, he said he usually doesn't drink, but about once a week, he'll binge out on a 30 pack usually. And for family history, only significant for mother having diabetes.
All right, James, thank you. Maybe I'll tackle the rest of the HPI and leave the past medical history, social history for Robbie to tackle. But here, when you're approaching the complaint of abdominal pain, I think first and foremost, you want to rule out life-threatening causes like obstruction, vascular catastrophe, or perforation. We're really not getting the sense for a life-threatening cause based on the HPI. I'll be very interested in the physical exam that James shares with us. So now we have time to take an anatomical approach. And here it's really hard to localize because the patient has flank pain, which could suggest an extra abdominal organ having pathology referring to the sort of lower abdomen, the kidney specifically. And what can happen to the kidney? You can get stones, infection, infarction, all sorts of processes. But something I think unique about the HPI that James shared is the multiple location of pain that the patient is experiencing, meaning we're not dealing with an isolated process. It almost is as if this disease is involving the retroperitoneum and the anterior abdomen. The constipation is interesting in itself, James. That grabbed my attention. Normally, it's not a center of gravity, but for a young person coming in with abdominal pain, with constipation, it makes me curious as to what might be causing it. For example, electrolyte disturbances like hypercalcemia can lead to constipation and abdominal pain. Anything that causes constipation can cause diffuse abdominal pain, though I wouldn't expect retroperitoneal abdominal pain. You do want to get a urine tox screen because opiates can lead to constipation. They can lead to abdominal pain. And I think that's very important to consider in any patient, but especially a younger patient. So what I do with this HPI is my mind is sort of tracking the multiple locations, the flank, the anterior abdomen. The constipation is quite unique. It makes me think about potentially an electrolyte derangement or some kind of toxin that's decreasing the motility of the small intestines. But in reality, I can't make much more progress than that. I think the exam and the labs will be quite telling.
Oh, did you hear that leap to the retroperitoneum? That was amazing. It wasn't on my radar, and I'm right there with you. The medical history is important. I say the background is important for a couple of reasons. I think we all expect 31-year-old patients to be healthy, but you can start to make maybe a non-evidence-based list of what might affect otherwise young people, and substance use disorders are certainly near the top of that list. And here, how can you relate alcohol to abdominal pain, nausea, and vomiting? There's many connections. Some of them you can diagnose with a high degree of confidence. In fact, some of them you can diagnose with essential certainty, which is pancreatitis, hepatitis, alcoholic hepatitis, and actually ketoacidosis. So alcoholic ketoacidosis is another one. So the three you can say, I know this patient has pancreatitis, I know this patient has alcoholic hepatitis, and I know this patient has starvation ketoacidosis. And there's a couple of things that slip under your radar, meaning that you can make this diagnosis, but it's not as firm. And that is an alcohol-related gastritis, alcohol-related esophageal disease in the form of a tear, and most fun of all, which will hopefully trigger some Googling from the chat, gastrointestinal beriberi. Yes, it's a thing. Probably not happening today. But hey, if you're on VMR and you don't hear esoteria, something is going on. Less esoteric is the connection of marijuana to the abdominal pain, and most patients who consume marijuana at high levels don't get this syndrome, but there's a very important thing to know about, which is called cannabinoid hyperemesis syndrome. And your clue may be that the patient has a burn on their back, as Reza might testify. Why? Not because he has a burn on his back, because he discussed a patient who had a cannabinoid hyperemesis syndrome, where the clue was that the patient had a burn on his back from extremely hot showers. The other connection with marijuana and abdominal pain is to recognize that vaping is the most common cause of vaping through marijuana or nicotine can cause a pulmonary GI syndrome characterized by respiratory failure, but a lot of patients have GI symptoms. So where does the background layer on to the foreground? I think the substance uses are dominant here. And remember, you can prove three things related to alcohol use: pancreatitis, hepatitis, and starvation ketoacidosis. Know that there's some things you can't prove but commonly invoke, like alcoholic gastritis. MJ plus abdominal pain is cannabinoid hyperemesis syndrome. Your clue might be a relief with hot showers. But all those are don't land as much with the hypothesis of retroperitoneal pathology. So we'll have to keep those as guiding clues, but certainly not drop the anchor here.
All right. And actually, one thing on our differential definitely was the cannabis hyperemesis syndrome. So a little more with the past medical history. Over the last 2 years, he has had 3 ED admits for this abdominal pain, nausea, and vomiting. And one of the things is he did know that it did get better with hot showers. Fortunately for the interest of this case, that wasn't the final diagnosis though, but I can give his vitals an exam now though. And for vitals on the ED admission, temperature was 36.6. His blood pressure was 147/88. Heart rate was 65. His respiratory rate was 18. And he was satting 100% on room air. For the physical exam, generally, he did look like he was in acute distress, a little diaphoretic. He had just been vomiting a little bit before I'd entered the room to start my exam on him. But his vomit was non-bilious, non-bloody. HENT was normal. Same with cardiovascular exam, normal. Pulmonary, no lungs were clear to auscultation bilaterally, no crackles, no wheezing. The abdomen was not, it wasn't tender to palpation. Bowel sounds were heard in all 4 quadrants. Nothing concerning for the abdominal exam. Neuro exam, he had no numbness, tingling, no weakness in the extremities. And for extremity skin, mostly he was just a little bit diaphoretic, but nothing that was grossly abnormal on exam.
Maybe I'll just, oh, sorry. No, go ahead,
I was going to say, if you want, I could, if you guys want to talk about from here, you can, but I can give you some of the initial labs if you like.
Yeah, no, whatever you had planned. I know you put a lot of thought into this case, so go back to whatever you had planned.
All right, so I'll just give you the CMP and CBC. And so for his CMP, his sodium was 136, his potassium was 3.8, chloride 104, bicarb was slightly reduced at 21. His BUN was 10, creatinine 0.8, glucose 126, and his calcium was 11.6. CBC was normal, and his liver enzymes were normal. He did have a albumin of 4.9, and we checked a lipase on him too, which was 11. And just to note, his corrected calcium was 10.9.
Terrific. Maybe I can reflect on the exam and then have the Reza think about the labs. And the exam here tells you that there's something wrong with the presence of diaphoresis, but is relatively otherwise unremarkable. And so what model can you begin to take when you're worried about somebody as evidenced by the diaphoresis, but the exam doesn't tell you? And I think this is a humble reminder that when anybody has a complaint that involves the thorax or the abdomen, unlike the extremity, there's so much hidden underneath the skin. I'll tell you, when somebody has pain in an extremity, I will find that out on exam. I'll feel the reduced pulses, I'll feel the edema, I'll feel the rash. But when there's abdominal pain without much pathology rising to the surface, that doesn't really tell me much. And so I often rely on other clues to tell me, am I worried about this patient or not? And here the diaphoresis is ample evidence that they're sympathetically activated, and I need to look. How can you remember this forever? This is what we talk about with pain out of proportion when we talk about acute mesenteric ischemia. When somebody has acute mesenteric ischemia, they are on a lot of pain and they report a lot of pain, and yet you, the examiner, can push and push and push, but because you can't push on the vessel that's causing the ischemia or affect it, patient is unaffected by your exam. So here the question is, am I not worried at all? Because I could come up to the ER right now feeling just fine and tell somebody I have excruciating abdominal pain and my exam would be normal. But I also could have acute mesenteric ischemia and have the same issue. So how can you differentiate the two? You have to rely on anything else. And those other things come from the labs, which Reza will reflect on, but also anything that is concerning, the abrupt onset of it, the lack of prior history of it, sinus tachycardia, fever. And here the diaphoresis tells me, hey, this patient needs labs. I need to get to the bottom of what's going on. All right, Reza.
That was brilliant. And I will tell you, I'm going to be very honest with these labs, James. By the way, you are doing a terrific job of presenting this case. I just want to echo what Robbie said. You put a lot of thought into it. James, can I just ask for 2 additional data points? It's related to the basic labs. Do you remember, was the hemoglobin concentrated, was a little higher than normal?
Yeah, so it was a little bit higher at 16.8.
Great. And then one last thing, James, the upper limit of normal of calcium in your lab, and if you have a specific gravity of the urine.
So I did not write down the specific gravity of his urine, but I want to say it was, I'm trying to remember, it was less than 1.005 or greater than 1.025. It's one of the extremes though, but and in our lab, a high calcium, the upper limit was 10.
10, got it. Thank you, James. So first of all, you want to interpret labs in the context of your patient's presentation. The same way you want to interpret exam findings in the context of your patient's presentation, you want to do the same with the labs. So when we look at this labs, we know this patient has lost some volume from vomiting and from not drinking fluid. So this patient is a bit concentrated, and this is supported by the higher than normal hemoglobin, higher than normal albumin, higher than normal calcium. And the specific gravity of 1.025 equates to about a urine osmolality of 600, 700. So this patient is concentrating their urine consistent with the state of hypovolemia. The bicarb is peculiar. Usually when people are vomiting, not only are they losing that acid-rich content, but they're also activating the renin-angiotensin-aldosterone system. Aldosterone secretes hydrogen ions in the distal nephron. So you expect such a patient to be alkalemic, not acidemic. Of course, you cannot make that interpretation on a Chem7. The only thing you can diagnose acid-base disorder-wise on a Chem7 is an anion gap metabolic acidosis. So this would prompt me to get a VBG to know what is the patient's pH, and then to do an assessment for this low bicarb, which is just surprising. The fact that it's 21, maybe it would have been lower if the patient wasn't vomiting and losing acid. So when normal or slightly abnormal isn't slightly abnormal. So what do we do with this calcium? So we all want to get excited, but let's just be honest. This is not a high calcium. It isn't. This patient is concentrated. I would give this patient some fluid and then reevaluate. Quite frankly, I'm not even yet ready to unleash I love hypercalcemia. One of my favorite schemas. I get to talk about phosphate, chloride, the phos-chloride electrical neutrality, but I'm not going to do that yet until we get more data. For me right now, I don't know if this calcium is signal, but Robbie, let me ask you, like, what do you think? I know we're in this environment and we want to hang on to something, right? Like this is a case conference. There's going to be a cool diagnosis at the end. We want to say, wow, look, it's hypercalcemia. Let's say, is this PTH, non-PTH? This has to be it. But I'm just trying to be authentic to like what I would do in real life.
And I will match that with my own authenticity. There are a number of times this comes up in real life where calcium is actually pseudo hypercalcemia, where it's actually not real. I would say is the majority of my experience in the emergency room, where the first calcium is high and then you give the patient fluids and then you never hear about it ever again. And if you follow up the patient, you'll see that they actually some of them might have evidence of what's called normocalcemic hyperparathyroidism, which is an entity I learned about very recently from a tweet that Tiago put out. But like, is it the center of gravity of this case? Maybe, maybe not. But the question here in my mind is, was the pretest probability of true hypercalcemia higher owing to the constipation, and which is unusual in a 31-year-old man, and higher owing to the flank pain, which might represent a kidney stone? I don't know, but there's no way that I would be sending off a PTH right now. I'd be hydrating the patient and seeing what happens.
All right, and I'll give you two more of the lab values that I withheld for this. So his magnesium was 2.0, his phosphate was 0.6. And
all right, James, you have my attention, my friend. You have my attention. So now the center of gravity is hypophosphatemia. This is the center of gravity. But not only is it the center of gravity, this should make you nervous. A phosphate less than 1. This patient is at risk of respiratory and cardiac and neurologic compromise. This patient's at risk of death from respiratory depression and just the muscles not working. Phosphates and ATP. If you don't have ATP, how are you going to move your muscles? So the complications of hypophosphatemia, the ones we worry about, include heart failure, arrhythmias, respiratory depression. You can have rhabdomyolysis. You can have neurologic compromise. We can approach this problem of hypophosphatemia the way we approach any electrolyte abnormality that's low, like potassium. Is it being lost from the kidneys? Is it being lost from the gastrointestinal tract? Or is there some kind of transcellular shift or exchange? Maybe what I'll do is I'll start with the kidneys, then pass it to Robbie to discuss the rest. So when we deal with the kidneys, you can ask the question, is it related to a hormone? Which hormone causes phosphate to be released? Which hormone is the phosphate thrashing hormone? PTH. So could this patient now, I would be interested in a PTH level. And in fact, if you did the chloride to phos ratio here, it would be greater than 35. You see, we all want to maintain electrical neutrality. So for every phos that you lose, negatively charged, your body's going to reabsorb chloride. So if you can calculate the chloride to phos ratio, if it's above 35, I'm sorry, if the phos to chloride ratio is above, if the chloride to phos ratio is above 35, then you're worried about a PTH mediated process. So PTH is something that causes phosphate thrashing. FGF23, now this is associated with some tumors, and it can act similar to parathyroid hormone to cause excessive loss of phosphate from the kidneys. Then you can have proximal renal tubular acidosis that you can lose a lot of phosphate. But for those, you would also expect bicarb in the urine, and you would expect glucose in the urine. So that would be interesting to see. But given this patient is so young, and given the calcium is just not that high, boy, could this be FGF23? I'm not sure yet, but I would be interested at minimum in a PTH level to start the workup for the hypophosphatemia. But let me pass the mic to Robbie to comment on some of the other causes of hypophosphatemia.
I love it. Brilliant. The other causes are really lost in the cells or lost in the GI tract, one of which is much more common than the other. Your phosphorus vanishing into your cells is one of the most common causes of hypophosphatemia. And that's when you can borrow from the playbook of other things that vanish into cells, potassium. So what causes potassium to vanish into cells? Insulin and beta agonism. And so those also push phos into the cells, causing hypophosphatemia. When I say insulin, I don't just mean exogenous insulin, also the endogenous release, typically as a result of refeeding syndrome can do it too. So when phosphorus is lost in cells, it's usually lost because of insulin, exogenous or refeeding syndrome, or beta agonism when you give your patient albuterol. But phos is a much more complicated electrolyte than insulin because of two things: its use in bones and because of its importance in formation of ATP. So acute respiratory alkalosis or hyperventilation triggers phosphate moving into cells and is the most common cause of acute hypophosphatemia we know. The other cause is hungry bone syndrome, where after a parathyroidectomy, the bones are like, give me my phos back, and they take it all back. So what causes hypophosphatemia? Borrow from your K playbook: insulin and beta agonism. And then what's unique to phos? Its need to make ATP, and the trigger is acute respiratory alkalosis or hyperventilation, but also bones that are eating phos away, usually after a parathyroidectomy. But the GI tract can malabsorb phos typically because of a low vitamin D, but also because of phos binders that we give patients in end-stage renal disease or certain esoteric malabsorption syndromes like celiac disease. So where'd the phos go? The kidney, the cells, or the GI tract? The only cause of concomitant hypercalcemia is hyperparathyroidism, or PTH. But as Reza talked about, the calcium may be noise here and may vanish away with hydration. But the problem is the phos may vanish away with supportive care and may be driven by hyperventilation and the shortness of breath. So either we'll be left with a center of gravity anchored in hypercalcemia and hypophosphatemia, or after fluids and some excellent care by student Dr. James Plum, we may be left with a normal calcium and a normal phos, and we're back in quicksand. We'll see where James takes us.
So we did start supplementing this guy with some phosphate. So we used just like 40 millimolar phosphate with normal saline. But while we were doing that, we did get a PTH and a vitamin D25 level on him. And so that PTH was elevated at 107 and the vitamin D25 at 18.3, it was decreased at. And unfortunately, we did not get a activated 125 vitamin D on it. But and yeah, I'll leave you guys with that before going on to the next stuff, and then the next will be the revealing aliquot.
Okay, maybe I can talk about the PTH and have Reza reflect on the vitamin D. There's an alphabet soup when you see a high PTH, and that triggers the analysis of whether your patient has primary, secondary, or tertiary hyperparathyroidism. The easiest is tertiary. Tertiary hyperparathyroidism is when the PTH goes up as a result of advanced kidney disease, and that's not at play here. So the question is, are we dealing with primary hyperparathyroidism or secondary? Secondary hyperparathyroidism refers to compensatory increase of PTH as a result of a low calcium or a low vitamin D. Primary hyperparathyroidism refers to autonomous function of the parathyroid gland where the PTH drives hypercalcemia. Now, I said we know that tertiary is not at play, but it's either primary or secondary, and that's a lie. Why can't it be primary and secondary? There's a definitive case for a component of secondary hyperparathyroidism because the vitamin D is low, and that accounts for a small fraction of the PTH elevation. But that alone doesn't cause the calcium to go up. So here we're probably dealing with a mix of primary and secondary, with the secondary being driven by vitamin D deficiency. But I bet if you gave this patient and repleted their vitamin D, their PTH would not normalize. So then we're left with, okay, this patient probably has hyperparathyroidism autonomous. And the most common cause of hyperparathyroidism is primary idiopathic, a little bit more common in men than women. But there are some genetic syndromes that can do it and some medications that can do it. And the genetic syndromes are a laundry list of things which we won't talk about. And the meds that can do it are lithium primarily, but some other ones. So here I'd be most worried about primary hyperparathyroidism with a component of secondary hyperparathyroidism from the low vitamin D. But I'll leave the low vitamin D reflection to Prof. Rez.
Oh man, I really have nothing to add to your excellent discussion, Robbie. And at the end of the day, I think if we took everyone's vitamin D level, and we can ask Tiago to comment on this, it's going to be low. We're all vitamin D deficient. And vitamin D is supposed to be the cure of everything. It's supposed to fight against COVID, cure of so many diseases. And I think there's probably 1,000+ articles about vitamin D levels. But ultimately, vitamin D can be ingested. It can be created from the skin after exposure to sunlight. And you have various forms of vitamin D. You have 25-hydroxyvitamin D. The liver is responsible for that. Then you have 1,25-hydroxylation of vitamin D that occurs in the kidney. And we don't have a 125 vitamin D level. But Robbie, I don't think, for me at least, that vitamin D is going to be the center of gravity. I think that it's an interesting finding. The high PTH may be converting more of the vitamin D to 125 vitamin D because PTH acts on the kidney to assist with that 1-alpha hydroxylation. But yeah, I think we have to figure out why this patient has hyperparathyroidism and take the approach that you so eloquently laid out.
All right, and I can actually, before I reveal the actual diagnosis with the imaging, one more study that we did do was a 24-hour urine calcium, and that was elevated at 421.8. So if I don't know if you guys want to discuss that a little bit, or
Go for it. Oh, okay.
oh,
That's an important test to get in this situation. I would love for Tiago to reflect on it actually, but I think you have to screen in your evaluation for primary hyperparathyroidism. You have to single out one disorder because the treatment of that disorder is very different, and that disorder is FHH, so familial hypocalciuric hypercalcemia, and that's in patients that have an interesting PTH sensing mechanism. And the typical treatment that we pursue for most common causes of hyperparathyroidism does not work for those patients. And so the urine calcium is really helpful in that it is, as expected here, it's really high. Parathyroid is resorbing calcium, dumping it into the urine. FHH would cause a low calcium, typically less than 200, I believe. So it's good that we've rolled that out because we don't want to mistreat that condition. So that's what I say that the urine calcium adds.
all right. So we looked back on some of his labs from his prior admissions, and he actually had, it looked like he had this hypercalcemia for over the last about 2 years now. And it was mostly his nausea, vomiting seemed to be chalked up to cannabis hyperemesis syndrome, especially since I feel like we see that a lot in the hospital that I was rotating at. But we did end up getting a sesame scan on him, and it showed a parathyroid adenoma in the left thyroid gland. And so there was only one enlargement. And so we consulted with endocrine surgery, and they decided to bring him back in, remove the adenoma.
James, that was fantastic. And how did your patient do?
So he actually did really well. When I saw him the morning after the surgery, I went in, asked him how he felt, and he said, "Oh, I feel awesome." Unfortunately, we didn't get a discharge him that day because he tried eating a bunch of food too fast, which we told him not to, and then he ended up vomiting that up. But that was mostly due to the not really having eaten over the last 2 days. And so we kind of warned him about that, but he was all excited that he finally has appetite back. So but yeah, he ended up doing really, really well. And so one of the things about PTH is it has an extremely short half-life. It's about 5 minutes for the half-life of PTH. And so they tend to check that pretty much almost right after the surgery's done to see where that's at. And his PTH ended up falling back down to, oh, where did I write that number? So it ended up being a little bit low. And maybe I didn't write his number back down. But it ended up dropping a little low, which in the adenomas is pretty common, because once you have this one gland that goes haywire, that starts acting inappropriately and secreting too much PTH, the rest of the glands aren't secreting them because they're acting appropriately to the calcium levels that are actually in the blood. And so they tend to hypertrophy a little bit. And so it usually takes about 6 weeks is the time that they tend to fully catch up. And the patient is usually expected within that first 6 weeks to notice the vast improvement in their symptoms. But it can be up to about 6 months where they notice gradual improvement after the 6 weeks typically. And so with him, he did have slightly low calcium levels after the surgery. So we started supplementing him with vitamin D even before the surgery. But then we recommended vitamin D to continue to take that. And that if he became symptomatic with the hypocalcemia, to supplement calcium, even though it's not the recommendation to take supplements of calcium just to get in your food from day to day, just because it's been linked to negative cardiovascular effects by bolusing a bunch of calcium at once. So the day after that, we ended up discharging him, and yeah, he was extremely happy that he could finally eat food, and he kind of had an answer for what was causing these symptoms over the last 2 years, because he wasn't really, it could have been maybe a little bit of the cannabis hyperemesis syndrome, a little bit, because he obviously did get better with the hot showers, but it was mostly definitely that hyperparathyroid. And if you want, I got a few teaching points for parathyroid adenoma.
Please, James.
So one of the things we had to obviously look into was, treatment for hyperparathyroid. And for a hyperparathyroid adenoma, usually, surgery is the way you want to go because it's curative. And there are a few criteria that you'll look at. Some of the ones being if they're symptomatic, which in his case he had, the constipation, abdominal pain, which, we learned from the mnemonic, stones, moans, groans, psychiatric overtones. And so he definitely had this constipation and this abdominal pain, nausea, and vomiting. So he had been symptomatic over these last 2 years with these episodes. Then some of the other criteria that some of the endocrine surgeons like to see is a 24-hour urine calcium, they like that to be over 400. And but age is a big one, which age under 50, they strongly recommend, which just because you have this parathyroid adenoma, it's going to keep on getting bigger and bigger and bigger and secreting more parathyroid hormone. So you're going to run into more problems the longer that you tend to have one of these. And so usually in the age under 50 is a good candidate to have the surgery done. And then also for the primary hyperparathyroid diseases, there is parathyroid adenomas and there's parathyroid primary hyperplasia. And so luckily in his case, he had the adenoma, and we were more confirmed of that because after removal of the one, his PTH levels dropped down, meaning that, you know, his other 3 glands, neither of those were inappropriately secreting PTH. And the problem with when you see hyperplasia is, one, from a surgery aspect, they tend to be, you know, you're removing more than 1 gland. You may be removing anywhere from 2 up to all the glands. And also the hyperplasia is typically associated with, you know, your genetic mutations, MEN1 and MEN2A, which, you know, can be more concerning, and you'd probably have to have a lot closer follow-up on these patients to make sure that, you know, they're not having any kind of pituitary adenomas or like a pheochromocytoma. And so from his standpoint, at least, it seemed to be a pretty favorable outcome and diagnosis for him. And so he hopefully should be good. I think it's only about 2% of people that have an adenoma removed within that 6-month period end up having to, you know, have some kind of reoccurrence of this. But usually the adenomas are due to environmental exposures that cause a mutation in just one of the cells in the parathyroid, which causes inappropriate sensing of calcium, opposed to the hyperplasia tends to be just a genetic mutation at birth that they tend to have. And yeah, those are some of the points that we just jotted down.
James, thank you. You brought an incredible case. You had it prepared. You delivered amazing teaching points. And this is bread and butter medicine. And we luckily have an amazing endocrinologist that I would love to hand the mic to just get his thoughts on this case and any other teaching points he wants us to take away before getting the mic to Rafa. Tiago, are you in a place to unmute yourself and share your thoughts?
Oh yeah, thank you, Reza. And I think that it's very important, the point that you mentioned and Rabbi mentioned, you both were perfect about vitamin D, and I want to reinforce it. Vitamin D should not be taken by the general population. It should not be taken. It does not treat COVID, but it's very important in this case. It's very important to get vitamin D in this case, because, you know, PTH is high because there is a disease in the parathyroids. But then he has a low vitamin D that is not related to his disease. But PTH is destroying his bones, right? So you do not want another reason to have a high PTH. You do not want it, because then his bones will be more destructive. So you just give this patient vitamin D, and then it's probably that PTH goes low, and then it will be better for his bones. And also after the surgery, you can have the hunger bone syndrome, which looks like happened here, because, you know, PTH is very high, so calcium and phosphorus, they are going out of the bones, and after having the surgery, these bones, they want calcium and phosphorus, and then you'll have hypocalcemia after the surgery. So if your vitamin D levels are higher, it's less likely that you are going to have a hypocalcemia after the surgery. So I see many physicians, they do not like to give vitamin D to these patients because they say there is a hypercalcemia. If I give the patient vitamin D, the calcium will be higher, but that's not true. The calcium is higher because of the PTH. You should give these patients vitamin D. So I think it's very important, this point of the vitamin D and the hunger bone syndrome. And men one should be taken into consideration here, as James cited, but it's hyperplasia. And so this case is just as adenoma, and adenoma is more common. It's 95% of the hyperparathyroidism. And just one little point that is very important. Everything that is related to hormones, do not use image unless you have the diagnosis. So as James and his team did, first, you decide that it's PTA dependent hypercalcemia. So now you know it's primary hyperparathyroidism. Then you look for the gland. And if you find it's better because the surgical management is easier. So that's what I have to
And actually,
reinforce your points.
I have a quick question, because I was looking this up, not really able to find a good answer. And so obviously with a hyperparathyroidism, you have, this problem with bone wasting. And when would a DEXA scan be recommended in these type of patients? Or
all patients. So it's an indication for surgery. There are 4 points you cited then. Age under 50, hypercalcemia, 1 point above the upper limit range, hypercalciuria, and nephrolithiasis or nephrocalcinosis, and a bone density that is less 2.5. The T is less than 2.5. Or for this case, as is a young man, the Z is less than -2, which is a low bone mass, is an indication for surgery. So this patient would have surgery because of his age, but it's an indication of surgery, the bone mass density. And for bone mass density, there is another important point. Use the distal third of the radius, because it's cortical bone. And in primary hyperparathyroidism, you have more, it affects more cortical bone. So you can have a normal density in your lumbar spine and femur, and then you see the problem in the radial bone, and then it's an indication for surgery. A patient with 55 years old, not calcium is not so high, but the T score for a woman here, like less 2.7, it's indication for surgery.
All right, cool. Yeah, because I educated him that, because obviously he's following up with endocrine now, and that they may do this bone scan on him within, from what I was able to find for some reading points, was usually within that first month after the surgery, they'll get a bone scan, and then tend to track that after about 6 months. But I don't know if, it varies from institution to institution or not.
It varies. Yeah, it's just before surgery, it's important to indicate the surgery. But in this case, it was indicated regardless of the bone mass density.
Yeah. All right.
Incredible stuff. I think Travis is pointing out that you all should be getting CME for this. That is 100% true. And James and Tiago were talking, we're learning so much from them. But I would say that CME is I'm gonna double down on the CME credit, because you're in for teaching points from the one and only Rafa Medina, who just wiped off the smile off his face and got all serious. He's about to deliver, y'all. Pay attention. Take it away, Rafa.
So much pressure. So thank you, James, for the case. Like a really, really interesting. Thank you, Thiago, our endocrinologist consultant. Actually, Thiago also helped us on Monday night during our reflection that we had. So thank you, Thiago. So we had this young patient with nausea and vomiting, and the rabbi reminded us it's a mark of severity. Most cases don't point towards RGX. We have to focus on the other symptoms. And then when it comes to dyspnea, 95% of the causes are related to the heart or the lungs. When it comes to the heart, we have to think about myocardium problems, the pericardium, the endocardium with the valves, and also rhythm problems. And then when it comes to the lungs, we can also have an other anatomical approach, thinking about the alveoli, especially if the alveoli is singing, just like Rabbi always teaches, the parenchyma or the vasculature. And last common cause, we could think about anemia, acidosis, anxiety, hyperthyroidism, neuromuscular weakness, for example, ALS. And something that I learned with Alex last Sunday, the dyspnea is actually exacerbated when lying flat in these patients, like with patients with heart failure. And then when it comes to abdominal pain, we have to rely on things like obstruction or perforation or ischemia or inflammation. And there's this spiral that rectal exam for everyone and pelvic exam for women are always indicated. And then we try to combine the health-related behaviors that this patient had with abdominal pain. So we thought about his use of marijuana that could be leading to cannabinoid hyperemesis syndrome. That alcohol could be leading to pancreatitis, alcohol related to hepatitis, also esophageal tear. All of that could lead to abdominal pain as well. And then we talked about the constipation. It's very concerning in a young patient. We should think about diet. Is this patient taking adequate water or fibers? We could think about hypercalcemia, opioid use, ALS as well, IBS, hypothyroidism, and endometriosis if this was a woman. And then when it comes to dehydration, we saw that this patient had higher albumin, higher hemoglobin, higher calcium. We have to hydrate these patients and check again. When it comes to vomiting, we have to think about hypokalemic, hypokalemic, metabolic alkalosis. And then, which was the pivot point of this case, we saw that this patient have low phosphate, and we have to be really cautious because it could lead to neurological and cardiorespiratory disorders because of the ATP depletion. So we thought about causes that could be leading to the low phosphate, like the kidneys could be involved with PTH, type 2 RTA, but also GI losses with low vitamin D, phosphate binders, celiac disease, or transcellular shift with insulin and beta agonists. And then there's this rule that we can use the chlorate phosphate ratio, and if it's greater than 35, we have to think about PTH. And then when it comes to PTH, we have to think about primary cause like parathyroid adenoma or hyperplasia or lithium use, or secondary causes compensatory to low calcium or vitamin D, and also tertiary causes with advanced CKD. And then we have to rule out familial hypocalcemic hypercalcemia. We have to check the urine cause for that. So because in these patients, they require a calcium higher than normal to suppress their PTH. So thank you everyone. Very interesting case. Thank you everybody. Hope to see everyone tomorrow.